to, but the and actually the government said that each patient it occur 1,200 US dollar each patient, and then by the decrease it's only for treatment. Let's say so if sorry, mungkin biar lebih ini boleh saya jawab dalam bahasa aja ya. Oke, mungkin
I'm
jadi.
Sorry, Pak Eksa, please in English because we.
Oh, sorry. Okay.
Yeah.
Okay, and then we have a lot of budget from government to decrease it, and then that's why how we are going to show that by let's say from the cluster 1 the treatment is different with cluster 4, and we can see that with the cluster 4 treatment there is no let's say if someone have HIV, okay, that's you should get the treatment, get the ART, and then we can say that in the table 4 or the from the result we can find that the if someone with HIV known that he have HIV and then have the treatment, it become decreasing the budget from let's say government to expand it, and that's what I mean. That's how we try to make it clear. Maybe that's answer from me. I hope it made clear for Mr. Budi. Thank you.
Okay, thank you, Pak Eksa. I think time is up for you. So we can continue to the second presenter from University of Indonesia, Ibu Hanin. Please, time is yours now. Ibu Hanin, please.
Okay, wait, hold. Try to present.
I'm sorry, everyone, can you hear my voice?
Yes, I can hear you.
Okay.
Okay. Okay.
Sorry, I have to turn off the video for, because there is a.
The signal is not stable.
Well.
Okay. Can I start? All right. Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Good morning, everyone. May we be given help by Allah Subhanahu wa Ta'ala in this pandemic situation. Well, HIV/AIDS is a sensitive issue of the people in Indonesia, and its spread continues to increase every year. According to the World Health Organization, World Health or WHO, there are three main problems faced by people living with HIV/AIDS. The first is physical problem, the second is social problem, and the third is economic problem. Since the first case of HIV/AIDS in Indonesia in 1987 and its development until December 2019 tends to fluctuate. The peak data for the case of HIV/AIDS in Indonesia occurred in 2019 as many as 50,282 cases was recorded. Data based on Direktorat General P2P Indonesia. According to the data from the Ministry of Health of Republic Indonesia, in 2019, 74% of the patients affected HIV/AIDS had additional expense, a living expense, because of being infected with this virus. Therefore, on this question, I would like, later I will just giving the abstracts about my research. Okay. Therefore, on this equation, I would like to present my research regarding of the coping strategy of PLWHA through economic empowerment by describing how stakeholder the collaborations, coping strategy, economic empowerment, and people live with HIV/AIDS in Sukabumi. I would like to introduce myself. My name is Hanin Pradita Nur Sultani. I'm a final year graduate student, Master of Social Welfare Program, University of Indonesia. Okay, next. The content of my presentation consists of the background, the data and methods, research, and also conclusion. Next. Okay, if you look at the table or presentation, in Indonesia, the highest number of HIV infection, including the three highest provinces, such as East Java, DKI Jakarta, and West Java. Okay, and the highest cumulative number of AIDS case, the 5 provinces is Papua, West Java, Central Java, DKI Jakarta, and West Java. West Sumatra. The spread of the HIV/AIDS virus in Indonesia doesn't only attack by homosexual, but also commercial workers and then homemakers who are infected by their husbands and teenagers, and also the children whose the mothers are infected of this virus. Next. Later, when someone has the HIV/AIDS or getting the AIDS, they will be faced the emergence of AIDS. Its name is wasting AIDS or AIDS wasting. It can be said that someone who has AIDS will be lose some weight. It's about 10%, which is obtained by accidents. They can feel like diarrhea or feel like so weak, and then also feels like fever is it's almost 30 days after they get the HIV or they get the AIDS. Wasting remains of the problem of people living with AIDS, despite preserving the RV. So the triggers of the another the HIV, it can be go to the deadness. Okay. Not only the wasting problem faced by someone infected of the people living with AIDS, because according to the data from the Ministry of Health, the patient affected is also state that they have additional living expenses. So that's why economic problems can be interpreted as a special problems experienced by people living with AIDS. So the economic problems occur from job losses and the problems in business development owned by people living with AIDS. Okay, next. The social support. So the social support is from the government and then the community has given by people living with AIDS can they improve the quality life of people living with AIDS. Thus, this intervention of the model presented, the government and the community is the economic empowerment. Next. Okay, this case of my research is located in Sukabumi, and it can be said there has been increase per year since 2000 from the first case of HIV/AIDS found in Sukabumi. Next. The formulation of problem based on the above about the background. This research can be formulated with the following question. The first, how's the collaboration out by stakeholders for the economic empowerment activities from the micro enterprises living with HIV? And the second is, how do micro enterprise economic empowerment activities become a problem focused coping strategy for people living with AIDS? Next. Okay, this data and method, this research used the descriptive method. The data collection technique used this study were document review, in-depth interviews, and direct observation related of people living with AIDS, stakeholders collaboration, economic empowerment, and also problem-focused coping strategies. Next. The informant framework has a 3 criteria, such as key informants, service providers, and policymakers. The key informants, there are 3 people living with HIV/AIDS, And then service providers is for people, the KPAD Sukabumi, and then Sukabumi City Health Office, and also Lensa Benika is the NGO. And the third is policy marker, policy marker. Setelah Sukabumi City, and then Kejar Mimpi, it's the there are two people. Next. Okay, the result on this slide, I will present the result of my research. So the economic empowerment carried out in collaboration with stakeholders in front of providing capital and providing training to people living with AIDS who already have a small business. So the problem of people living with AIDS are accommodated by the NGO Lensa Bhinneka, which is then the voice of people living with AIDS, which create the collaboration between stakeholders. Next. Okay, the result of the collaboration process, if you look at the chart of the collaboration process according Vigoda and Gilboa 2002, in our study, the voice of people living with AIDS is a provider or the main for the information on economic problem to developing their business. So have here the explanation of the collaboration process on research. There are 6. The first is about the deciding a problem. This is because the listening the voice of the problem of people living with AIDS will form a collaboration to the 3 pillars. It is KPAD Kota Sukabumi, Lensa Bhinneka, and also the Kejar Mimpi. So these 3 pillars finally decided that the economic problems of microenterprise for development people living with AIDS are the problem that will be carried of the stakeholder collaboration. And the second is the collaboration, the characteristic, the problem, to what and where. So in the process, the collaboration participant has this own character and also the rule. Each collaboration, the participant must also contribute to finding a real or the idea so that the result can be achieved. In this result showed that the relationship between people living with AIDS and also the stakeholder collaboration is going well. Of course, they're listening problems and become the core problem. So development micro entrepreneurs can collaboration form. So, and the rules of the 3 pillars is also formed. So the third is about the finding out who is involved in the collaboration. So the clarity of the roles of these stakeholders makes this collaboration more effective and efficient. In this research, the rules has been formed between both people living with AIDS and also the stakeholders, thus providing economic empowerment of micro enterprise of people living with AIDS through the collaboration inform a problem solving that will be carried out of the collaboration. And the fourth is finding out who in the implement. Here more the emphasis of the excellent communication and effective the management time in carrying out the collaboration. So we can say that the management of training and the capital is led by stakeholders involved and carried out by the result of joint discussion that have been determined, and the determinant is jointly. So the classification is the carry out of that the beneficiaries and the directive. So the fifth is about organizing collaboration. So in the successful implementation of the collaboration is cannot spread it from the readiness of stakeholder involved the collaboration process. So it means from the result, the study is also seen that this collaborative activity is well established between stakeholders and people living with AIDS. So the support provided the 3 pillars of collaboration is expected to continue run well and provide great benefits to people living with AIDS. And the last is about the evaluating the collaboration process. So this is the evaluation is carried out, see how the collaboration has given an assessment of the result of the collaboration activity. So Evaluation is carried out by providing monitoring, and also stakeholder is turns out the capital is stage. So people living with AIDS are also given the greatest opportunity to discuss to use the capital with stakeholders. And next, how about the result economic empowerment? So economic empowerment of micro enterprise for people living with AIDS, it's not necessarily to do with conformance. The first is strengthening the profession of capital, and the second is strengthening skill and earning income based on Karta Sasmita 2008. So in the result of the study, the three informant E, S, and L, so interest and developing the business for the each informant. According to the table presented, I tried to give the result where the carrier of the information is. The first is strengthening capital provision. If you see that informant E is adding workforce, so the capital to increase workforce for his workup business is the main of the strengthening provision of capital from informant E. Informant S utilize the giving the capital is maximizing the product. So by buying some products that has been sold for his business, and informant L is take the advantage to the capital provided, but the difference with informant S, informant L using to increase the assets like buying some glass shelves and also refrigerator to sell the cold drinks and next is strengthening skill. Informant E is utilize the training has been obtained by maximizing the marketing strategies of their workshop business, and informant S is like utilize the training obtained by maximizing capital. It's the same with informant L, but the difference is like how they use the capital it is. So the earning incomes, informant E from the result with the utilizing the profession and the capital obtained by increasing the workforce, it maximize the profit uh, of their workshop business. Informant S is like the result is utilizing the profession and capital and training obtained by adding selling products, so it maximizes consumer who buy. And informant L from the result utilizing the profession of the capital, it's obtained the equipment, so it's maximize the appearance attractive of their workshop. Next. How about the problem-focused coping strategy for the people living with AIDS? Economic empowerment of microenterprise through stakeholders collaboration is part of coping with people living with AIDS. These studies use focus problem coping because it takes the real action to the change of the business condition to have owned by people living with AIDS. So we use a theory, the problem-focused coping strategy by Taylor, 2006. The classification have three. The first is confrontational coping. The second is seeking social support. And the third is planful solving. Next. Okay, on the research, I make a summarize. The first is informant E. This visible problem-focused coping strategy is plain problem solving. The activities training and activity in collaboration because he is always active and enthusiastic to get information of the business development. So he has already have planned what will they use for the capital they get. And then informant S, the visual problem focused coping strategy was seeking social support and plans problem solving. So this is the initiative. So informant S is initiative to use or to maximize the capital he gets. So she still needs help to others to make decision for the business development, even though she plans made by the very minimal. And informant L, The feasible problem focus strategy was seeking social support and plan problem solving. It's the same with Informant S. The difference is Informant L has already know what will they use to get the maximize the capital, but they're not sure is it correct or not to uh, to make the maximize using for that, and so it's still need for the people to help by unlimited providing it. But for the three informant of the research, from the result of study, the converting copying was not feasible. So the strategy of the research doesn't lead the aggressiveness of stakeholders of people living with it. So the provision of capital assistance training is not it's not a profit and required of people living it to pay the installment. So in the problem focused copying strategy, just one theory is not too feasible on this research. Next. Okay, the conclusion. I minimize the conclusion. The first is the voice of people living with AIDS is the beginning of the micro enterprise economic empowerment activity. So the problem of solving is directly a problem focused coping strategy from people living with AIDS needed. So but people living with AIDS is a real from the activity change the problem they face. And the second is the success of micro enterprise economic empowerment activities cannot be separated from the cooperation carried out by stakeholders and cannot be separated from the high intention of effort of people living with AIDS and to develop their business. So that's all my research presentation. Feel free to ask questions. Thank you. Wassalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh. Thank you, Ibu Hanin. Very excellent presentations. Please, audience, any questions, comments, or suggestion? Okay, please, Pak Adiatma Siregar.
Yeah, thank you for the opportunity. And thank you for the presentation. I apologize, I cannot turn on my camera at this moment. So yeah, let me just proceed with the question. Ibu, I think your research is quite interesting. Yeah, and there's also a bit similar program in Bandung City, but I don't think it's still ongoing. Now, the thing is, what we did back then is we focused on housewives because they're I think the more they're willing to collaborate more, yeah, in comparison with the other high risk groups. Now, I just would like to have your opinion. How do you see this program to be expanded to reach the other risk groups in your view? And how do you see the program as something that's sustainable? Yeah, basically that can be embedded into the local HIV program. Thank you.
Okay, thank you, Pak Adiatma. The first, I'm so very read your journal about the in Bandung City. That's my reference for this program, for this research, because this is research is my final graduate. So I'm using your journal to get the research reference of.
Oh, thank you.
So I'm so proud that you asked this question. All right, I try to answer your question for the first and how to reach a group. That's the problems, honestly, because we have people not this, or we can say the community have a trust issue for the people living with AIDS. For example, when we have sense the capital to the people living with AIDS, the trust issue is coming up like bakal digunain seperti apa, like how they use the capital use. It's possible to make they buy products or something like that. So in this program is give the capitals, but also to evaluate, like give the programs with the pelatihan with okay, with the training and also with the give the capital. So they give a lot of trainings with the stakeholders. Stakeholders is helped out with the give the training to the people living at AIDS who has a business. So we cannot give the capital without people living with AIDS not to have the business. That's why the characteristic to uh, to make that the rich group it's continually. So, and the second question, sustainable. So that's still for the research is how to make its program sustainable. Honestly, this program is end of 2019, and then until now the stakeholders still give the uh, give the constructions or give the development of fundings to people living with AIDS. So they always give the people living with AIDS who has to get the capital found is also give the report to the stakeholders. So after they finish the trainings, they must be give the reports about the maximize the capital. So that's why it can be see or it can help to stakeholder to evaluate about this program. I think that's all my answers. Thank you.
Yeah, thank you. It's a bit tricky, isn't it? Yeah, you empower a group at one side, and on the other side, you're battling stigma, etc. So, kind of, it's a tough road to walk on. Yeah.
Yeah, that is tricky, and this the program is also they try to give the capitals with free without the payback, but the other ways they want to give the best of people living with it. Yeah, that is a tricky program. That's why on the results or in the advice of my my research is also give that the answer.
Okay. Yeah. Okay. Thank you, and best of luck. Yeah. Best of luck.
Thank you.
Okay. Thank you, moderator. Thank you.
Okay, thank you, Pak Adiatma. Is there any other questions or comments for Ibu Hanin? Okay, probably from me, Bu Hanin. This is very interesting research. And I'm just wondering, because I don't have any I don't know, pictures about people living with HIV and AIDS. And it seems that, as you mentioned, that the program gives them capitals to run their business. And I'm just wondering, because they are in a condition of sickness, so how you control that the program will be successfully applied to them?
All right. The informant is there are 3 informants because this pandemic we the totals for this program is 15% at 15% of people living with AIDS, but because this pandemic I just get the 3 of 15. So the 3 of people living with AIDS is different backgrounds. The first if informant is the background is they have bengkel motorcycles, and the second is about the warung sembako, and the third is warung sembako also. So the first because the bengkel motorcycles or the motorcycle services is needs their skills and also their physically the quiet they have need the one work fast to get the capital, so they can add the work fast to help out the motorcycle services. And the second, because they feels like the stigma socials, like they she before she gets the HIV, or because she gets the people living with AIDS, the informant S is works in the factory, and because this is people because gets AIDS, the body is less weight, so the people ask, but kok kurusan ya gitu, so and why kok your change is so different, like she's worried about the people knows about their AIDS, so they out and then they try to open the warung, and with the less capital, so with these capitals they can help to build the not the bigger, but to make products more like right now, so because they don't have the income from the build the warung tersebut. So and the third is about the informant L. Informant L is the different background. They have more capital but more skill, but they have the few apa ya, the point view of the how to build the warung. So that's why they need she needs really the capital to help out about to build the warung in home. So there's no need to out and then to feel like a stigma from the others. I think so. That's all my answer. Thank you.
So, I mean, even though they are sick, they still can do something for life, right?
Yes, they can still do living because the living is so much go on, so they need to survive about the how to get the income from their life.
Okay, thank you.
Yeah, thank you.
Yeah. Any other questions or comments from the audience? We still have a few more minutes. I think 1-2 minutes. No other questions? Okay, thank you very much, Ibu Hanin. Very interesting research, and good luck for your next research. Okay, please, the last but not least, presenters. The last presenters is going to present from Universitas Padjadjaran also, I think.
Yeah, okay.
Pak Fariza, okay. Forum is yours now. Thank you.
Previously, can you help share the screen from student assistant?
Yes, wait. Can you see the screen now?
Yes, it is clear.
Okay. Previously, we would like to inform you that the title of our research paper has changed when yesterday we submitted the latest paper, and we have communicated with the committee, especially Kak Wening. Assalamualaikum warahmatullahi wabarakatuh. It's an honor for us to be able to present the result of our research on this occasion. And we are economics undergraduate students. Let me introduce myself. My name is Muhammad Faisal Akbar Putra from the Department of Economics, Padjadjaran University, and along with my two other partners, Putri Nabila Akmal and Ananda Sinitya Putri, will present an economic research paper entitled Disparities in Rural and Urban Tobacco Use, Socioeconomic Factors, Influences on Adolescent Smoking Behavior. Next. Okay, let us start with a question. Do you think that adolescent smoking affects people's health more and has a more negative impact on someone with a lower economic status? And have you ever considered how geographical differences can influence tobacco consumption patterns? And did you know that according to the Global Adult Tobacco Survey, about 61.4 million teens use tobacco in the form of cigarettes and or smokeless tobacco, with 59.9 million teenagers are smoking tobacco. And sounds very concerning, right? And based on this, we try to conduct research to analyze how these socioeconomic factors will influence tobacco use behavior in rural-urban adolescent. And this slide will consist of several outlines with an introduction, research background, research questions, literature review, results and discussion, recommendation, and also conclusion. Next.
Our research background show that 0.82% of cigarette consumption in rural area is higher than in urban area. People in rural area are 3 times more likely to consume cigarettes than urban people, with a ratio 1.7 times in urban area. Higher level of cigarette consumption in rural area reflects delayed access to health and low socioeconomic factors. Next. Tobacco consumption is a global problem that causes various disease, disability, and death, making it a significant impact on health of Indonesians. The disparity in tobacco use in rural-urban area account for most the increased burden of chronic respiratory disease, cardiovascular disease, reproductive disorder, and diabetes in Indonesia, where adolescents are the group with high cigarette consumption, with 11.84%. Next.
Okay. Tobacco kills more than 8 million people each year. More than 7 million of those deaths are the result of direct tobacco use, such as cigarette, while around 1.2 million are the result of non-smokers being exposed to secondhand smoke. The impact of smoking is increasingly felt during the COVID-19 pandemic. Smokers are more at risk because the chance of transmission of COVID-19 for cigarettes is greater. The act of smoking is using leaves, either conventional cigarettes or electronic cigarettes, and lead to increasing the transmission of the SARS-CoV-2 virus through more aerosols. Another study shows that smokers are twice as likely to die from COVID-19 than non-smokers. Based on this situation, Indonesia needs a comprehensive smoke-free policy and tobacco control programs. Next. Okay, based on our research background, we have several research questions. The first one is how the disparity of socioeconomic factors can influence the tendency of adolescent smoking behavior. And the second one is how the different patterns of adolescent smoking behavior in rural and urban area. And the third one is what policy are appropriate to reduce the tendency of smoking behavior in this area. Next.
Okay, furthermore, in this literature data and methodology section, we begin by identifying a suitable sample of variables to be able to estimate tobacco use behavior. And in our study, the use of cigarettes among adolescents aged 10 until 18 years old was used as the dependent variable, and it was categorical variables, with non-smokers being coded as 0 while smokers being coded as 1. And also age, gender, work status, income classes, education level were the independent variable we used to indicate socioeconomic factors. And we also included geographical factors in our study to examine if there is a disparity and difference in cigarette consumption behavior between rural and urban areas. And these geographical factors is a demi variable with urban coded as 1 and rural area coded as 0. Next slide, please. Okay, in several previous literature studies, it is often that tobacco consumption is a global problem and that causes various diseases and deaths, and high tobacco consumption are teenagers. Meanwhile, tobacco smoking behavior is defined as the practice of burning tobacco and ingesting the smoke that is produced. And the fact that we quote from the WHO says that tobacco kills up to half of its user. And also a previous study by Stevens, Cowell, and Hutchison found that cigarette use was more common in rural and than urban settings. Their study explains that more than 80% the world's 1.3 billion tobacco users live in low and middle income countries, with the majority of them suffering from poor lung function, asthma, and also respiratory infection. Next slide, please. Okay, the data we used during this analysis is the 2019 SUSANAS as cross-sectional data. And likewise, we use this data to see the disparity between rural and urban areas. After that, we classified the other 5 predictor variables. The first one, age, is a continuous variable that is categorized for the adolescent age range 10 until 18 years old. The second one, gender, is a nominal variable. And the third one, employment status, is also a nominal variable. And for this variable, we define those who work as part of the workforce, whereas who do not work are classified as part of the non-labor force. Within this context, it includes people who are currently studying at school, housekeepers, and also other non-personal activities. And fourth, income class as a nominal variable is formed from the component of household expenditure per capita at the national level. Then we divide it into 3 groups: low class, middle class, and also upper class group. And in this study, we also classify the income class as a low class group, representing 40.1% of the poor, middle class group representing 40% of the moderate group, and an upper class group representing 90.89% of the rich group at the national level. And the 5th variable is the level education as an ordinal variable, which we divide into 4 groups: primary, secondary, and also higher secondary education. Next slide. Okay, the methodology that we use in our analysis is multivariate logistic regression analysis to estimate the expected probability of the influence of socioeconomic factors, determinants on teenage tobacco smoking behavior in rural-urban settings. And for each analytical test, we also consider the respondent's life, and therefore we must limit the observation to random samples based on the needs of our analysis, where the observation in both areas are less than 2,050 people, then we interpret using a marginal effects coefficient. And the right one is the model that we use in our analysis. Okay, next slide.
Our research paper provides results about the composition of difference in cigarette use and determinant of adolescent smoking behavior in urban and rural in Indonesia. Next. Why are smokers in rural area higher than in urban area? Our research showed that smokers aged 10 to 18 years old in rural area are 65.19% and in urban area are 34.81%. So smokers in rural area are higher than urban area, with the difference is 30.38%. Next. The higher number of adolescent smokers in rural area is due to differences in socioeconomic condition between the 2 regions. Let's look at the work status factor, where the high population of adolescents in rural area who already have job with a percentage of 60.26% resulted in higher cigarette consumption rate adolescent in rural area by 36.48% compared to urban area, as well as for adolescents who do not work, with a composition of rural area of 68.24%, also resulting in composition level cigarettes higher by 20.52%. Then, if we look at the education level, rural area have a declining education pattern, or it can be said that the population of teenagers with primary education is large. In contrast, urban area have an increasing pattern, so that the lower of education obtained by adolescents in rural area resulted in higher adolescent smoking in rural area. Next.
Okay, from this table of regression results, we found that there is impact and different patterns, and we can see that income classes in both rural and urban areas are not statistically significant associated with the probability of adolescent cigarette use. And besides that, socioeconomic variables such as age, gender, employment status, and education level have significant predictors and influence the probability of using cigarettes in their teens. And as you can see for the age variable in urban areas, if the population age teenagers 10 until 18 years old increases, it will increase the average probability of using cigarettes at that age by 0.143 percentage point. And meanwhile, in rural areas, for every increase in the population of adolescent, the probability of using cigarettes at that age will increase by an average of 0.22 percentage point. And we take a look at Stevens, Cowell, and Hutchinson previous studies, which claim that higher rates in rural areas are related to two factors. First is the lack of access to education, not to smoke, due to lower educational attainment. And second one is the delays in healthcare access to medical and media resources. And the next, for the gender variable, male adolescents have a higher probability of using cigarettes by an average 1.54 percentage point than adolescent girls in urban areas. And besides that, in rural areas, the probability of using cigarettes among teenage boys is average 1.88 percentage point higher than that of teenage girls. And we found that others previous research from Estro Daryatnosi Halo Chat Unpad shows that in Indonesia, the prevalence of smoking for adult male is 82.7, while adult female have a prevalence of 3 in 2020. And then for the employment status, we found that those who enter the workforce and being work affect the probability of using cigarettes in their teens. And another study found that people who were unemployed for a longer period of time not working had a higher tendency to initiate or increase cigarette use than those who were not unemployed with working. Next, for the education level, we found that there are different patterns of cigarette use. And on a primary level, students in urban areas will have a higher chance of reducing their probability of smoking as teenagers than students in rural areas. Again, we take a look at Stevens, Cowell, Hutchinson previous studies, which claim that one of the reasons for the difference in the probability effect of smoking at the young age in rural areas is the difference in affordability of implementing school-based danger of smoking education programs starting at the elementary school level in urban rural areas. And in contrast to the elementary level, at the secondary level, as you can see, students' probability of using cigarettes in urban areas has a smaller effect on reduction compared to those who don't attend school in rural areas due to the more educated population in urban areas. And its conclusion is that the disparity of the education level group tends to reduce the probability of smoking in adolescent as the level of education of a person increases in both urban and rural areas. And the last part from income status was not significantly predictor, surprisingly. Its income class in both urban and rural areas does not significantly affect the probability of adolescent cigarette use. And it's the same result as Buttersmith, Miller, and Max previous studies, which showed that tobacco consumption is more normalized into culture, especially those belonging to the upper income class group. And next.
Okay, based on our analysis, we have several discussion. The first one is World Health Organization Framework Convention on Tobacco Control to protect people from the health and environmental impacts caused by the consumption of cigarette smokes. There are several factors that why Indonesia does not ratify the World Health Organization FCTC. Tobacco sector is one of the source of revenue for state cover sizable. If Indonesia ratified the FCTC, then tobacco consumption will be declined, and it is feared that it will endanger the fate of local tobacco farmers. The decrease in tobacco consumption is also feared to have an impact on economic stability in the country. Next slide, please. In fact, Indonesia still depends on tobacco imports. Another World Health Organization's research found that local tobacco production grew stagnant by an average of 1.65% for 27 years. Meanwhile, tobacco imports to Indonesia continue to increase, even doubling every year. Next slide, please. The second discussion is cigarette excise tax. Our analysis or study shows that higher smoker is in rural area. Rural area have a higher number of smoker by 30.38 compared to urban area. The lower of the price of cigarettes, the higher the level of smoking consumption, especially in rural area. Because many rural people with low to middle income can buy cigarettes in retail. Another study shows that most people from rural areas do disagree with increasing excise tax because they were considered detrimental. Next slide. Okay, we have several recommendations. The first one is government's policy recommendation, and the second one is our innovation campaign called Quit with IRSA. Next slide, please. The government policy recommendation we have, the first one is ratifying the Framework Convention on Tobacco Control in Indonesia, and the second one is increasing cigarette excise tax in Indonesia. Next slide, please. Then we adopted a campaign called Quit with IRSA, which consists of 4 movements, namely influence, reduce, educate, and stop. The first movement is influence, where the form of this movement is to invite teenagers, especially passive smokers, to be active and dare to talk about their disadvantage they get while in the smoking environment. Also invite passive smokers to dare to fight for their right to be in a smoke-free room. The next movement is reduce, where this movement aims to invite the public, especially teenagers, to sign a petition related to the ratification of the FCTC for the government, and agree to increase the price of tobacco products and increase cigarette excise to be allocated to the national health insurance budget, such as a JKN. Then Quit with IRSA was continued through the educate movement. This movement focused on providing information about harmful substances in cigarettes, especially during the COVID-19 pandemic. And after doing some of Quit with IRSA movement above, the last movement that will be done is stop. And that's where this movement evaluates what teenagers have done in the previous Quit with IRSA movement. Next slide, please.
And the Quit with IRSA campaign centrally has several advantages, such as the increasing the rural society as a whole, but active smoker and passive smoker, increasing youth activity in rural areas, and also the government role to provide policy related to tobacco control and tobacco products that are more comprehensive. In addition, rural communities get more detailed information about the danger of smoking through direct educations. Next. And in the conclusion, for our research show that adolescent smoking in rural area is higher by 30.38%, that the socioeconomic factor that influence the prevalence of adolescent smokers aged 10 to 18 years old, with the variable of age, gender, work status, and education level have a significant relationship and influence on the probability of using cigarettes in adolescents. But on the income class variable in both urban and rural area, the two are not significant. In dealing with cigarette consumption problem, efforts are within to tobacco control both from the government and the community. And through with the Quit with IRSA campaign program, we hope to have the potential to reduce inequality between adolescent smokers in rural and urban area and overcome tobacco control. Next. That's all our presentation. Sorry for our shortcomings. Thank you for your attention.
Okay, thank you very much. Very interesting presentations. Please, audience, if you have any questions or comments for them. So you guys are master students or undergraduate students in Unpad? Mas Faisal?
Undergraduate student, ma'am.
Wow, that's great. You already do excellent research. Okay, audience, please, if you have any questions. Oh, there is a question from Rafli Ahak from the chat. So may I read it for the presenters. Based on your findings, I want to asking about your thoughts on why do people with a secondary level of education have less impact in urban areas than in rural areas. Is there any previous research that describes this problem? Okay, that's the question from Pak Rafli Al-Haq. Okay, please. The presenters, you might answer the question.
Okay, thank you, Pak Rafli Al-Haq, for your question. And yes, of course, from our result study, we can find out that the disparity of education level group tends to reduce the probability of smoking in adolescents, along with the increases in a person's education attainment in both rural and urban settings. And as you can see before that, in this situation, the secondary level educated persons in rural areas are thought to be better capable of minimizing the probability of smoking in their teens. And based on our findings, also we find one of underlying causes from the paper written by Gupta and Ray, 2007, that this condition shows that adolescent students who are taught about the dangers of smoking in school are less likely to initiate tobacco use, and thereby reducing the probability of tobacco use. And that is why I think misspent youth, of course, also contributes to the error term that may affect the result of our research. Maybe my answer.
Sorry. Any other questions or comments?
May I ask a question too?
Sure. Wenning.
I'm an economic undergraduate student from Faculty of Economic and Business, Universitas Gadjah Mada. Do you think that the ownership of health insurance or the implementation of the health program from Indonesian government will affect the pattern of cigarette smoking behavior in post-rural and urban areas? If so, how will you put that into the models? Thank you.
Okay. Mas Fariza, please.
Okay, sorry for, you can try your question.
Okay, maybe you can repeat again the questions, Mbak Wenning.
We all know that Indonesia government is also giving a health program such as BPJS or another private insurance, health insurance. How would you think that the health insurance or the health program from the government would affect the pattern of cigarette smoking in both rural and urban areas? If so, how would you put that into the models? Thank you.
Okay, so this is related to health insurance and health programs for people in Indonesia.
I want to try answer your question. I think personally, in Minister of Finance that implementing JKN, we have apa namanya, the Access Law number 39 of 2007 mandates that excise on processed tobacco products at the highest 57% of the retail price, but a further increase in excess duty as regulated by Minister of Finance is also allocated as income for GKN, and we bring that this mind to our analysis for economic status variable in our model. I think that's all.
Okay, so it means that you can put in the model as one of independent variables. And you suggest that, if I'm not mistaken, you suggest that it will be influence the behavior of smokers, right? And yeah, because I also think that if people get in health insurance, and there might be increasing probability that people think that it is okay if I not quitting smoking, because if I get sick, the health insurance will cover my health expense. So don't you think what I'm thinking? I mean, it's health insurance will increase the behavior of smoking instead of decreasing. What do you think?
I think it's the same from our results, yeah. And there's impact and different pattern also in educated people in urban areas. And as you can see, education attainment has a negative impact on high probability of cigarette use. And maybe my partners want to explain that.
Okay. Friends of Mas Faisal, maybe you can add.
Yes. And I said that there is a pattern of different education level and in urban and rural area. So the age is make a difference. Like primary education level in rural area is high population than urban area. Maybe this answer. Thank you.
Okay, so you mean that the pattern of the behavior will be similar with the pattern of with the effect of education on the behavior of smoking, right? Okay, thank you. Is there any other questions or comments? We still have 1 minute, I think. No other questions or comments? Okay, thank you very much, Mas Faisal and friends, for the presentations. It's very excellent presentation. Okay, for everyone, thank you very much for this session. And we finish this session now. And I hope that it's give you all beneficials joining with this session. Okay, so I close this session. Thank you very much for everyone. And Assalamualaikum warahmatullahi wabarakatuh. Stay healthy, everyone. Thank you. Bye-bye.